So we're going to talk about Smile, which I've been performing now at Beach Eye Care for since August of last year. If you want to mute your microphones, you can. That may make for better sound. But if you have a question, don't hesitate to unmute and ask the question. So this is showing you the VisuMax laser. With it's a technology made by Zeiss, and we all have a lot of respect for Zeiss. So when we look at the timeline of laser vision correction, we started with PRK back in 1995 when it was FDA approved, and I performed PRK in 1996 when 20 physicians in 5 hospitals brought the first excimer laser to coastal Virginia. In 1998, LASIK was FDA approved. I started LASIK in 1997. In those studies, it led to its FDA approval on the VisX laser for myopia, then myopia and astigmatism, hyperopia, then hyperopia and astigmatism. Femtosecond lasers, and that's what the VisuMax laser is, became FDA approved in 2001, and we got the first in all of Virginia in 2002 with the intralays. So the intralays then to create the flap took 1.5 minutes. So imagine that pressure on the patient's eye, the blackout of vision, talking to them for 1.5 minutes to be still as the laser created the flap. So fortunately, it sped up and went from starting at a 7,500 pulse a second to 15,000 to 30,000 to 60,000. And the year after the iPhone came out, 2007, so it was 2008 is when we got the intralays that does the IFS, it does 150,000 pulses per second. So Smile, which is performed on the VisuMax laser, gained FDA approval in 2016. So you can kind of think of it as like the iPhone 10 version of femtosecond lasers there. So much advanced version there. So that was just for myopia. So we weren't quite ready to add Smile in when it could just treat nearsighted patients with less than a half diopter or less astigmatism. So first Smile cases actually were performed back in 2007 and widely accepted in the world outside of United States 2011 on. So March of 2017 was the first Smile cases. It became FDA approved for astigmatism as well as nearsightedness in October of 2018, and that's when we looked to add the technology on a Beach Eye Care, and it came to Beach Eye Care in July of 19 as the first in coastal Virginia and the first in Virginia with the VisuMax laser outside of Fort Belvoir Army Hospital, where they prefer Smile over PRK for the active military. So we're really correcting nearsightedness and astigmatism, creating this thin disc-shaped layer. So kind of it's a contact lens-shaped piece of corneal tissue is the best way to describe it, because most people who are nearsighted have done contact lenses at some point. And this is beneath the surface of the eye, removed through a tiny opening. So this is an animation of it, but we're going to get to look at the real thing too. And so with the femtosecond laser, it's a circular pattern outside to in. Down at the refractive deep layer, does the outside edge of it, then the top surface or cap, and then finally coming on up to the surface is the last step of the laser. This is all over a 25-second time period. And then we're defog it, is how I describe it to the patients, and remove that lenticule, that contact lens shaped piece of corneal tissue, to correct their nearsightedness and astigmatism. So we'll click on to our next slide here. Let's go past that one. So basically, what it has done over those 4 laser treatments there over 25 seconds, the first one, it starts deep and moves to the surface. So the first pass is based upon the patient's prescription for nearsightedness and astigmatism. The second pass is that lenticule, it finds a lenticule diameter. So that's a vertical cut at the outside of that lenticule. The third is the cap lamellar, and then up to the surface with the side cut that allows us to be able to remove the lenticule. So this next video is a patient March 17th having the laser part of her Smile, then the lenticule removal. Most patients' first Purkinje image tends to be, this is her left eye, her dominant eye, tends to be slightly nasal and inferior, and thus this is matching up with where her central visual axis is. So here comes the refractive pass, slightly oval. The laser slows from 500,000 pulses a second to 250,000. There's the edge cut. And now it's going to do center on out. And I'm talking to the patient, telling them that that green light disappeared, look on past it. Your vision's going to fog a little, and you can see the side cut down below. Next, it will transition to, under the same scope, the patient comes on out to give me this kind of view. I'm entering the side cut, and I'm in the corridor. So then I'd have to go over and under. So I'm identifying the over. Okay, so that's above the lenticule, and then I'm identifying the under. And you can see how it's defogging. I'm helping the patient fixate. I tell them your eye's going to move around. Just kind of look towards the light. You're doing great. Everything's going well. So now the over and under identified, we go to the spoon side of this Reinstein separator there. Dr. Reinstein's out of London. And now I'm defogging the top. And again, their eyes moving around, but nobody's complaining of any motion sickness or anything from this. And you can see this is about a 1.5-minute process to actually remove the lenticule. So it's pretty darn rapid. We've got the upper surface totally separated. Now I go low, and I'm working and loosening the central part down below. And then we'll go all the way across to get to go ahead and break the attachment there. But we'll leave a bridge over closer to the forceps that's fixating the eye. We'll go around the rest of the way. And now I want to get on top of the lenticule to be able to remove it. It's starting to fold up there. I have loosened now it all the way around. So I'm getting that to fold. And then to come on out here, as you'll see, with the next sweep. We will place it on top, stretch it out, make sure it's round or oval, and that we have removed all. Let's see, let's click on to the next one there. So now you've actually seen the surgery, and you're welcome to come with your patients or come observe somebody else's patients if you'd like to see how the patient experience is for SMILE. So when we talk about SMILE and what the VisuMax laser can do, it can create the LASIK flap as well. So I use it for creating the LASIK flap because it's gentler for the patient, as you'll see here in a moment, without that blackout of vision or pressure sensation. Intrastromal corneal rings for a patient with keratoconus. Used to perform those, but I'd stopped performing those when there are insurance coverage issues, and have not resumed those in more than a decade. Even keratoplasty, kinds of corneal transplantation, can be facilitated through the VisuMax Femtosecond laser. There's a voice guide if we put too much pressure on the eye. The German engineer's wife speaks in her German accent, but in English, to tell us to move up. We're putting too much pressure there. The bed actually moves the patient's eye up to be hugged there, so it is very sophisticated there. It makes adjustments if the patient's moving away a little. And as you saw from that high quality recording of surgery I had, we have that on every patient with a digital recording capability of the laser built into it. So the interface itself, and this is the VisuMax laser is the only one FDA approved for the SMILE procedure to date, uses the VisuMax laser uses a low energy. The contact is smaller and actually hugs the eye, so it knows that with the corneal curvature there. That leads to less deformation of the eye too. When we talked about that pressure going up and the temporary loss of vision, the patient, comfort or discomfort there, with the intralaser, a pressure of 150. Ouch. But it's not bad. I've not experienced the intralaser, but I've experienced the microkeratome. The VisuMax lasers, you can see the pressure barely goes over 50. Other femtoseconds, Femtech to 200, and the Femto LDV laser to 160. So those are high pressures that we don't have with the gentler VisuMax. We have less subconjunctival hemorrhages, so less of the red eye there. And that's just because this is a smaller interface that's hugging at the limbus and not going out to the conjunctiva and the sclera there where we can get those red spots. But we'll tell them, as we all do, that they don't hurt, they don't affect your vision. They'll clear up over the first week and nothing to worry about. So what does the patient experience? It's more comfortable. They've got an internal fixation target that knows the patient's prescription when they're having SMILE, so it's in focus for them. It's fast. The process of creating a flap, 17 seconds. The time to do SMILE, 25 seconds with the laser. It's quiet. There's no clicking noise associated with it. There's no noise or odor that you have with the excimer laser. The laser vision correction for nearsightedness and astigmatism is all done just on one laser, not two lasers. So this slide kind of summarizes those benefits there. We're seeing a faster visual recovery for patients getting to 2016, better than 20/20 vision, and 20/20 in one study that compared intralaser to intralaser and the Alcon femtosecond laser there. When they looked at another study, and I'll actually share my results with you with the group from December too here shortly. They looked at the intraocular pressure that we talked about, its benefits there being lower. Flap adhesion, when they did some studies in rabbit and donor eyes, it was less prone to dislocation than one of the other femtosecond lasers. Visual acuity with the quality and precise flap creation, we're seeing high percentages of the better than 20/20. And that's what we want to do. We want to do a vision correction procedure for a patient together that will give them better vision than they have in glasses or contact lenses. So that's possible today. And the suction stability is very good with very little suction loss occurring. So 4 out of 5 patients preferred the VisuMax laser when compared to the intralaser. So that's why I don't use the intralaser any longer. Workflow efficiency, if you can have a laser in the same room, then the chair, the table that they're on, or chair, whatever you want to call it, bed, will actually move them over to the next laser and they don't even have to get up. So we've not quite done that yet. We're centering on the vertex with centering flaps as well as, of course, the smile treatment. And there's less of any opaque bubble layer with the VisuMax laser, 5%, versus the intralaser, nearly 53%. When we look at the quick recoveries, the 2016 or better, the VisuMax and LDV femtosecond lasers perform well. They're all pretty equal when you looked at the 2020s. And this was at the 3-day post-op in this study, 1 week post-op, 1 month post-op, that VisuMax and LDV had the nod over intralaser and Alcon's laser there. So who can we treat with SMILE? Well, this is our nearsighted astigmatism patients, -1 to -10. Astigmatism is -0.75 to -3 diopters there. And the manifest refraction spherical equivalent, -10 diopters and under. So -10 is the max treatment. It's FDA approved for those who are 22 years of age or older. Of course, we want a stable refraction within a half diopter the last 6-12 months there. We can use it as a practice of medicine issue for 18 and older, 18 to 21-year-olds there, just documenting that it's an off-label use with their young age. These are just some of the energy settings and specifics of the laser. And the key thing to know is that we're working through a small 4-millimeter incision. Let's look at some of the pre-op considerations versus the 20-millimeter LASIK flap. So pupil size, really, not a factor. Small or large pupil size. If it's a small size, we might consider using a smaller optical zone if we need to preserve tissue with SMILE as well as with LASIK. Corneal thickness, we like corneas to be 500 microns and greater, but can treat down as low as 480. Generally, if they're under 480, we'll switch to a surface PRK procedure. So a Pentacam gives us a pachymetry map, and we also have that now too with OCT that can give us a pachymetry map as well that way. Gives us the limbus diameter white to white, so that's us relative to the size of an interface there can be key information. We have the K readings that are entered there relative to corneal curvatures. We've looked at topography to make sure they don't have an abnormal topography where they should have collagen cross-linking first, or PRK is their only option. Cyclopedic refractions are particularly important if we're dealing with hyperopia. SMILE patients who cannot have hyperopia, so those patients would be having far-sighted LASIK. Contraindications are the same usual ones as we have for any laser vision correction. And we like to diagnose things pre-op, so the surgery is not blamed for causing post-op. Dry eye testing is something we do with looking at tear lab and inflammatory in every patient pre-operatively there. And we like to see as normal a testing or get it as normal as we can there. So if there's insufficient corneal thickness remaining, that residual stromal bed, then we need to switch to a different procedure like thin flap LASIK with the VisuMax laser can do with a 80 micron thick flap. The accuracy, and we tested our laser and measured in the beginning, is plus or minus 3 microns, so very accurate. We want to not to rule out the abnormal topography. Unstable prescriptions, they need to stabilize, no active infections or inflammations. Same thing with autoimmune diseases, connective tissue diseases there. They need to be controlled first, like glaucoma, diabetes, not be pregnant, and of course, severe dry eye patients, not a candidate. So here's some of the things unique about SMILE. There's no flap, so we don't have to worry about a flap ever moving, even though it's a 1% risk in the first week and like a 1 in 10,000 risk lifetime of a flap moving. It's minimally invasive. The incision 4 millimeters, there's a 6 millimeter option, but I just use the 4 millimeter option, all done under one laser, no odor or noise. So the size of the LASIK flap and the 4 millimeter size of the SMILE incision. More corneal nerves are preserved, so more corneal nerve less decrease in sensation, less dryness of the eye. So the normal nerve plexus 360, with LASIK, we're interrupting 10 clock hours of that, regenerates over about 9 months, versus with SMILE, we're interrupting 1 to 2 clock hours of it, so much less nerve interruption there. Faster healing, so patients with SMILE wear protective shields that are clear the first night so they don't reach up and rub to give themselves an abrasion. Nothing they can move though. They are fine to shower the next day. They're done with the shields. They can wear makeup. I generally don't recommend that for the male patients. They can exercise in the gym and not really worry about perspiration getting their eyes. That tiny SMILE entry heals up for us rapidly overnight. Post-operative visits are similar to laser vision correction with LASIK and LASIK more so than PRK, in that we generally would see them the next day if they're available to do that. If not, we do a 1 week check, so 1 day or 1 week, and then generally a 1 month and 3 month visit. The 3 month visit is a nomogram. I think we've covered all the rest of things there. They're on an antibiotic drop for a week to prevent infection, generally ofloxacin. And a steroid drop on a tapering basis for a week as well, generally Pred. So I think we've covered all those things. And so this was the most recent FDA clinical study for SMILE with astigmatism. We'll look at those results first, and then we'll look at Beach Eye Care results, my results. So first of all, we're comparing with this. And let's see, I think what I need to do is I'm just going to minimize for a moment. The reason I did that is now you can see the coding of what these are. Otherwise, we were looking at these bars and not knowing what they were. So we're looking for 20/20 or better. The light blue is SMILE for sphere only. Okay. The spherocentral SMILE was 84%, 20/20 and better. We got 89% if you use topography guided, so that was a little bit better in the studies. 83% was eye design wavefront guided, so equaled that. 89% would be with the Nidec laser. When we got to 20/40 and better, you can see they're all pretty equal. That's at 6 months out. Well, how about at 12 months out? Well, 12 months out, 89% with the SMILE group, 93% with the topography guided, the wavefront guided dropped back to 80%, being 20/20 or better, and 20 happy for our patients there. And so that's really, I think, the best way to look at those. I'm going to go back to the big screen and the next slide. All I had to do was hit that button and there it was. So I think key ones here to look at, you can see in this group, they had -5.5 for the SMILE groups, and they're all pretty similar, minus 4.6, -6 diopters, and postoperative mean refractions there for these two, all very close to plano. A little bit of residual myopia there. Within a half diopter, 94, 93% for topography guided and SMILE, and 69% with eye design. And that's our goal, to be within a half diopter of that target refraction that we set. When we looked at 6 months out, and I think this is looking at the astigmatism correction. So astigmatism amounts were diopter and a half-ish, plus or minus a quarter. Postoperative were all right around a quarter of a diopter there, and you see the very good numbers 85 to 90%, all within a half diopter on astigmatism. So when they looked at these 328 eyes with a smile at 6 months out, the ideal right on zero is the blue line. The light green is plus or minus a half diopter. The red plus or minus a diopter. 80% of eyes within a quarter diopter. That's really the ultimate goal, to be that accurate. 93% within a half diopter is pretty darn good to be plus or minus a half diopter. And that was their study. So now let's look at our studies here in coastal Virginia at Beach Eye Care. So I took December 2019's patients because you had that temporary law where we couldn't see our patients to be able to see them for their post-ops. And so of 37 eyes, I was able to get 19 in for 3-month results. And we've got the blue, the light blue is the pre-op vision, and the dark blues are post-op vision. So pre-op, we had 26% 2016 and better. Post-op, 63% without correction, 2016 and better. 2020 or better was 95% pre-op, a little drop to 89% there, and we'll account for some of those patients here shortly in our discussion. Everybody 2025 and better. So very happy group of patients there. And this is our 4th month of performing SMILE procedures there. So a little learning curve before you kind of master a new technology. Uncorrected distance vision post-op versus their corrected distance visual acuity pre-op. So their 90% were the same. 11% one eye were worse there, the uncorrected vision. So 11% would actually probably amount to being 2 eyes there. And that was 1 line worse than they were in glasses, usually due to mild refractive errors, not seeing dryness of the eyes. This is the change in distance, corrected distance visual acuity. So we had 58% be able to gain 1 line of vision with or without correction. No change in 26 to 18%, and losing 1 eye, losing 1 line of corrected vision in 16%. That'd be about 3 eyes. And those would generally be somebody who was 2015 pre-op, 2020 best corrected post-op. And some of that too may be were they shown the 2015 lines. I encourage my staff to make sure we're showing the patient the 2015 line, give them that opportunity to see better than 2020. When we looked at their spherical equivalent refraction attempted versus achieved, the gray line's the ideal, the green line's plus or minus a half diopter, and red plus or minus a diopter. So almost all plus or minus a half diopter, just one barely over that. So very accurate in this group of distance vision eyes. Plus or minus 0.13 diopter, thank goodness we don't have to refract for that, was 63%, and we added to go to up to a half diopter, we were at 95% within a half diopter. And one patient that was a little bit on the more myopic side there actually had an entry error made that was not caught by me, where we entered in plus cylinder instead of minus cylinder, so that ended in a under correction for the patient, but we fixed that to get her to 2020 with a PRK enhancement. This shows for those 19 eyes, they were averaging that minus 4.3 diopters pre-op, and at the 3-month check, really, we did do refractions earlier, but did not put them into our data link software that allows us to generate our nomograms to know how to treat, plus gathers all this data for us to make it easy to show you and learn ourselves too. So that took us to being less than a quarter diopter, minus 0.10 on average spherical equivalent at 3 months out. Refractive astigmatism, we see that pre-op light blue, dark blue post-op. We have 84% within a half diopter. So less than a quarter diopter had gone to 68%. The being within a half diopter, add another 16% of that to get to the 84. Of course, switching signs on cylinder would lead to some astigmatism. And the other patient with that higher amount of astigmatism is one that has an epithelial implant, which basically means that there was some loosening of the epithelium at the SMILE entry, and it's clear cells you can't see that were inadvertently implanted into the SMILE pocket. And then they did not just regress and clear on their own, they grew and opacified. And then I've removed those for that patient to to get them to 20/20 vision. This is looking at target-induced astigmatism versus surgically induced. So what we were targeting for patients, and the ideal is for them to be within in that half diopter, and we just have a couple outliers, one overcorrected, that'd be the epithelial one, and a few other under responses there. The astigmatism angle of error, we want to make sure we're having as little change in it as possible. We like to see them be plus or minus 15 degrees, and we see we've got the large majority there that are plus or minus that 15 degrees, like 88%. And that was out of 16 eyes there. So worldwide, SMILE is the most rapidly growing procedure, with over 2.7 million treated eyes with SMILE. It took 6 years for the world to get to the first 1 million cases of SMILE. And then in 2 years, additional 2 years, it was at 2 million SMILE procedures performed. And this is just showing the number of VisuMax lasers in the world, 2,000 surgeons using it, and thus performing SMILE as well. More than 500 peer-reviewed publications, and we have more than 10 plus years with SMILE now, with more than 2.7 million SMILE procedures. 17% worldwide are a SMILE now versus LASIK and PRK. So this is just showing that growth over the years from the inception in 2011 with the VisuMax laser on up to nearly 1 million procedures of SMILE procedures performed worldwide in 2019. And yes, in my practice too, I find myself using SMILE more than LASIK and PRK for nearsighted patients. So it is the procedure of choice. So the kind of the takeaways: minimally invasive with its smaller incision. Don't have to worry about the flap complications there. Kind of a hybrid of LASIK and PRK. We've got that extra strength of PRK and the no worries about a flap with both PRK and SMILE, but we don't have that slow healing with SMILE. We get the quick LASIK healing with SMILE without having to worry about the slow healing of PRK, where it often takes 2 weeks to 2 months for vision to get to that 20/25 and better level. One laser, more comfortable, quicker healing, less disruption of corneal nerve fibers. So now it's question time, so you can unleash those mics, and let's see what questions you guys have. Fire away.
How much astigmatism can you correct with the SMILE procedure?
Up to 3 diopters. So if I have a
Really?
patient that's got, yes, 3.5 diopters of astigmatism, I'll direct them to LASIK. But if they're 3 diopters and less, we'll go with SMILE. Now, if somebody is at a half diopter on the refraction, it's good to show them 3/4. Most people will tolerate the 3/4 correction, and then I would do the 3/4 correction. If they're at they're spherical or just a quarter of SIL, then I'm going to drop them back to a spherical treatment. Great question. Keep coming with any other questions you guys have.
Yes, Dr. Nietrauer. What's been the feedback on their night driving?
Very good. No issues. No one has needed any night driving glasses there.
Wonderful.
Yes, yeah. And the removing that lenticule really helps in correcting spherical aberrations for the patients there. So
I would think, yes.
Yes, yeah.
Great
It does, and there'll be something to look at is how about other aberrations in quality of vision?
Right.
And that high 20/15 rate is quite exciting.
Very.
Yeah. So kind of our goal is, to work together. You guys have gotten educated about SMILE. Let's share a few patients having SMILE, and then we'll be able to have you as a certified integrated care surgeon for the SMILE procedure. We'll have Zeiss print up some nice certificates that we'll frame and give to you to put out for patients to ask you questions when they're motivated and interested to consider laser vision correction. So.
And one other
Sure, questions. There's no rush. Yours.
Pricing wise, is this pretty comparable to where you've been with your other laser procedures?
Yes, great question. And what we did there, those are my computer glasses, so it makes it a little easier for two eyes to see things. And looking at a computer screen for a long time, that's when I put them on there. Otherwise, my monovision's still doing pretty well from LASIK of 1997 and enhancements of 2007. So we made the cost the same. So in other words, if
Okay.
the patient's choosing LASIK or PRK with a technology like the Contour topography guided or iDesign wavefront guided, Smile is the same cost. And if they're it's a little bit less to have LASIK or PRK with the wavefront optimized. So they're not getting a custom treatment there. So that ends up being a $300 difference between procedure costs if they choose to go with a wavefront optimized LASIK procedure over a wavefront guided, topography guided, LASIK, or Smile. So we don't want cost to be a factor for the patient. We want them to be able to you pick and choose based upon their pros and cons.
Very good.
I tend to like, if I'm treating a patient with dysfunctional lens syndrome first stage, that's presbyopia. So if we use this presbyopia term, with our patients, and they say, okay, they're talking medical, and I don't know what presbyopia is. I just know I need reading glasses. That's really when the lens is becoming dysfunctional. So if we think of that as phase one, when they first start to need glasses to be able to read and see the computer, those patients that are 45 plus. I tend to prefer LASIK in the non-dominant eye because it gives us the lift the flap enhance to give them more when they need it over Smile. Smile to enhance is our ability to do that would be with PRK or CK. And the reason is we have a 120 micron thick cap. We don't have the ability to make that a 140 in the United States yet like they do elsewhere in the world. So if I had a 140 micron thick cap, I could create a 80 micron thick flap comfortably and have 60 microns of ablation space. I've got plenty of space between those interfaces. Whereas to have it be 40 microns with epithelial thicknesses varying and changing some after from patient to patient and after laser vision correction, it's not recommended to do LASIK after Smile, but we turn to PRK. Another advantage of Smile too is longer lasting. So looked at over 10 years, the enhancement rate for Smile, 0.5%, the enhancement rate for LASIK, 3%. We as patients, and for our patients, they like one and done. They want you to get it right the first time, and they're very happy with their vision. So makes it simpler for all of us, especially in this COVID era where we all have to think about seeing the patients less and being more efficient with our visits there, because we can't go back to seeing as many as we were.
Right.
Great.
Other questions, keep them coming. I love questions. All right. Well, if we've got everybody's questions asked and answered, thank you for taking happy hour with us. That's just iced tea I'm drinking. There's not bourbon, and there's nothing in the iced tea. Thank you for taking the time to listen and learn as we return to taking care of our patients together. We at Beach Eye Care are delighted to help in any way. I know I've worked with all four of you with patients over the last year. Thank you for that opportunity and trust to take care of patients together, and those doors are open for us to continue to do that for many years to come. Dr. Levine is another ophthalmologist joining the Turf Health team. So you'll have three of us available to see your patients and work together with you. We can do telemedicine, to your office too. If you want my opinion right then and there on the spot while the patient's there too, that we're able to do those things now, and those technologies will only increase more. Michael, any questions?
No, not really, but
Okay.
thank you for your time.
Gotcha. I know you unmiked, so we figured you were going to karaoke for us.
Maybe next time.
Yeah, Laura won't let you do that, right?
Yeah.
Yeah. I know my
Yeah.
wife will say I can't sing, so I'm definitely not going to karaoke for you. And he quickly turned the mic off after that comment. Mike knows I'm just a FOG, a funny old guy. But I like to think I'm old as 10 years
Oh
old.
no, really, thank you for your time.
So that's the way I'm coming. All right. No other questions? We'll wrap up and get on to dinner. You guys stay healthy, be blessed, and look forward to when we can get together in person for a dinner and an educational meeting. That time's a little ways off, but maybe later this year we'll be allowed to do those kind of things, small groups. All right. Thank you.
Thank you.
Thank you
Thank you.
so much.
You're welcome. Bye-bye.